Okay. Okay, now here's the basics of cervical adjusting. What you want, because remember, every adjustment that we're going to do is going to be to change the brain function. This isn't to change anything other than proprioception. Now, the things that begin in the neck, 93% of all headaches to 97% of all headaches. Carpal tunnel syndrome begins in the neck. Asthma, breathing problems begin in the neck. I mean, the neck is so vital. We're going to do a couple of different moves here. Here's the right side, here's the left side. We can see a slight left position of the spinous processes at the lower cervical, and then we have a right rotation at the upper cervical. We can also see possibly an inferior left occiput, but we're not quite sure. So we're not going to do a cervical challenge, which we're going to go through when we're studying the cervicals. We're not going to do anything other than I'm going to show you how to set up and how you can feel what the body is doing, because there's not going to be a lot of rotation. The locking out of this joint is going to be radically different than what you've learned. Okay? Okay. You recording?
Mm-hmm.
Okay. So what you want to do, you don't want to lift the head. Okay, not just because it's heavy. Here, scoot down just a couple inches. Okay, you want it in a somewhat neutral position. Now, when you're palpating, okay, you go up, and so you're palpating all along the curves. He should have a normal curve, he doesn't. Okay, but you're going to go along the planes of those facet joints when you're palpating. And when you're talking about a 60-degree angle of those facet joints. So when it's in this fashion, like that, you're going to palpate in that direction, that direction, that direction. So you're going along the natural curve lines, and you're looking for an increase in resistance. Because you don't have conscious control of these muscles. So it's just going to be at the bottom, middle, upper. Now, since he has a left rotation, I'm going to let his head rest here. Now we're going to do a spinous contact. Now, this hand is hardly touching him at all. Okay, it's just kind of resting. There's not going to be a lot of rotation. We're not going to lock it out the way the way you're taught. He's just going to be resting here. Now, if he had an articulating, say we wanted a contact on the left convexity where it would be an articulating pillar, which the presentation of that would look, is your spinous processes are rotated to the left. His are rotated to the left. If he had the right rotation, but a convexity to the left, we do an articulating pillar contact. Okay? So the difference between an articulating pillar contact and a spinous contact is going to be the rotation. Okay? And you're more likely going to get that rotation from the x-rays. So here, what you want to do is you want to change the firing of the paravertebrals. Okay? And you can do that because around each one of those joints, there's little tiny sensors. You got these joint mechanoreceptors down here. So all you're going to do is put pressure on it, okay, in the direction you want it to go, just for 3 to 5 seconds. Okay? That's going to change the facet. It's going to change the way the muscles fire, and you don't need to lock anything out. Okay? Because the more you turn that head, the more you bend that head, the more you're changing those joint mechanoreceptors, the more you're going to increase the tone of the muscles. Does that make sense? Okay, so the stuff you're taught is not correct. Okay, what this is, it's more neurologic, because every adjustment has to be focused in on changing proprioception. Okay, so now his head is elevated and it's resting. Okay, and it's not that I don't want to hold his head, but if I'm holding his head, he's not as comfortable. Okay, because he's thinking, holy shit, what's he going to do? I've seen too many martial arts movies. So now this, I'm just going to maintain pressure here. Now what I'm doing is I'm holding my hand straight. I mean, you can lock it in, but when you're holding your hand correctly, you should be able to draw a line here and a line here. If you're going to contact like this, the force loading is going to go in that direction, and that's going to blow out your wrist. So you want everything in alignment. Okay, and you're going to find out, we're going to train on adjusting, and it's going to be uncomfortable if you do it incorrectly. Okay, so this is going to be a spinous push where instead of going up at an angle, I'm going to go slightly at that direction. But again, everything's locked in. I'm just maintaining the pressure there just for a second, and then just a small impulse. Okay, so it's super easy. Now, at the right lower cervical, I'm going to do a slight articulating pillar push. Now, this is going to be right at C5, C6, so it's going to be in that direction. So maintain pressure, and then just a slight impulse. So there's not a lot of rotation, and it's almost like a Gonstead move when he's in the supine position, okay? Now, since most everyone has degeneration at C5, C6, and we want to get that curve back in, a nice finish, again, is to go in, and I use the distal phalange of the middle vulgaris. Do you remember? Pollicus, indicus, vulgaris, annulus?
Sure.
No? Okay. Okay. Well, I'm contacting, lifting up, and again, just maintaining pressure for a couple of seconds, and then a small impulse up.
Oh my God.
And those couple of seconds up changes the joint mechanoreceptors, so it relaxes, okay, the muscles, and you're able to gap that joint, cause an inflammatory response, and that's going to reverse into degeneration. Okay?
Can you explain the inflammatory response thing? Because they're probably like inflammation, bad.
Oh, okay. Arthritis is a protective response to the body, not degenerative. Okay, even though it's called degenerative disc disease, degenerative arthritis, it's not. These discs have a horrible blood supply. So what happens is, if there's a trauma, okay, that changes proprioception, that's going to lock in the muscles, that decreases motion. If you decrease motion, the disc decreases its joint height. Decreased joint height means that it becomes unstable. So what the body does, here I'm going to use you as a bench for a second. So what the body does, if there's decreased joint height, the body is going to increase the surface area, okay, for that unstable segment to stabilize it. So can bone spurs be eliminated in the body?
Yes.
Say Wolff's Law. I know you forgot. It was way back in like try two. Okay.
Bone gets remodeled or destroyed
Exactly.
according to the stresses placed upon it.
Oh my God! High five.
See?
Okay, so what this is an intelligent remodeling of the body to stabilize an unstable segment, caused initially by some type of trauma which decreased the nutrients to the joint. Okay, so what we want to do here, I'm going to scratch him really badly and cause an inflammatory response. Oh, so what did I just do? If I really scratched him, inflammation is how the body regenerates tissue. Oh, so what we want to do, we want to regenerate the discs. Okay, so we're going to cause an inflammatory response at the level of the disc. Okay, does that make sense? Mm-hmm. And then if there's also, from the result of that trauma, some misalignment or subluxation, we're going to apply pressure in the direction back to normal. Because health is its natural state. And they may say, well, how long will it stay? Should you relax the muscles before you adjust the cervicals?
I'm guessing yes. No.
Oh God, I want to hit you with this right now. You guessed wrong. No, it's good, young Padawan. That you said something crazy. Okay, good. Here, rise up. God, I came close to hurting you. Okay, is the body smart or stupid?
Smart, very smart.
It's smart? Really? Okay, I think you're right. Okay, so now since the ear is designed to be over the shoulder, for every 1 inch that heads forward, the pressure on the disc double. Yes or yes?
Yes.
Yes.
Okay, good. So if we have 1, 2, or 3 inches, can you pull up his lateral cervical? Okay, how much forward head carriage does he have?
About 10 millimeters.
10 millimeters. So he's got ½ an inch, so he has about 3/4 increased pressure. Okay, so instead of 12 to 16 pounds head, he's probably got about a 20, 25 pound head. Now, if that remains that way, wait, you said the body's smart, right?
Yes.
Oh, so if it's forward and we're increasing pressure on the disc, and that pressure on the disc is decreasing nutrients, then proprioceptive firings are going to strengthen these muscles back here to reposition the head, yes?
Yes.
Okay, exactly. So if you have somebody with massive forward head carriage, and proprioception is trying to reposition that head, you relax those muscles, which way is the head going to fall? Further forward. So, God, I almost said a foolish person. No, somebody who doesn't understand anatomy or physiology would loosen up the muscles instead of finding out why the muscles are firing. Okay, does that make more sense?
Yeah.
Okay, so what we're doing with corrective care, you're going to find that the muscles on the convex portion are firing and they're increasing a tone to straighten up the body because the muscles want to contract. You're going to find that the shoulder muscles are firing because it wants to reposition that head. Okay, does that make more sense? So what we're going to do, we're going to cause an inflammatory response, which is going to regenerate the disc. We're going to realign that, which is going to change proprioceptive firing. Changing proprioception means that you're changing the tone of those muscles, and causing an inflammatory response of the disc is going to regenerate the disc. Then once the disc starts to begin increasing its height, then the bone spurs are no longer needed and bones resorbed. And you'll see when we go over cervical case management, you're going to see several cases where bone spurs there, bone spurs gone. Okay?
So don't get a massage.
Massage is for romance only. You get the candles, you know, you get the vanilla something, you know. This is a class, okay? Okay, you keep, you know, hands on the table. Okay, okay, good.
Hardware.
Cool.
Wow.
I think there's, okay. Okay, so we're going to do a cervical challenge. I'm pulling up one of the more challenging cases, 13 neck surgeries. So there is only one movable bone, okay? But you have to know which way do you want to move it. Do you want to move it forward, sideways, backwards? What do you have? I mean, the x-rays are going to give you an anterior and posterior view. You can't get a lot from this because the body is going to be changing and adapting depending on the stressors or force loading that she's going through during the day. Yeah, 7 back surgeries too. I mean, you got to like the salesmanship of this. You know, surgery 9, don't worry, honey, a couple more will get you down. Okay, so this is going to be absolutely vital to understand how to assess C1. Okay? So volunteer, face down. Here, haul it over here. So what we're going to do, we're going to go through stuff that we haven't covered yet, okay, on a patient. Okay, now here's the right side, here's the left side. What we're seeing is the left convexity, apex L1, right convexity, apex L3. When we look at this, we're looking at a right lateral shift along with a left rotation here and a right rotation in the upper neck area. We're looking at forward head carriage and some rotation down through here. And at the low back, we're also looking at a compressed disc at L5S1. So we're going to go through how to assess that. Now, what you might also take note is the femur heads. The femur heads are off, so that means he has an anatomically short left leg, or he has compressed nerves here causing a flattening of the foot on the left, or he's got some type of digestive anomaly or compression of the nerve, which is weakening the production of the cartilage and meniscus, causing a short leg. So you can measure the short leg. If it's, say, for example, 10 millimeters, it might not be 10 millimeters after you restore the nerve supply, restore the intrinsic muscles of the foot, regenerate cartilage and meniscus in the knee, which is all possible. So you don't say, hey, that's short, let's give him a lift. Make sure that you do some more accurate assessments after you get the correction. Okay? Okay, good. So we're going to assess him. So first off, I'm going to check the paravertebrals. And this is checking the increased tone of the paravertebrals. And sure enough, he has an increased tone on the left-hand side. You can almost see it from where you are. This is low and this is high. Okay? Then I'm going to check it at an oblique angle on either side. Okay, the pelvis to look for some type of restriction, whether it's the pelvis, ilium, or a sacrum. Then, once I check that, I'm going to check upper cervical after I check the leg length. So, and then I'm going to turn him on his side, adjust. I'm going to do an anterior on him. We're going to do everything to check, but I'm going to do it in real time so you see how much time what we've just discussed takes. Okay, so real time, you're just checking leg length. Okay, I'm just going to apply a little pressure here just for a second. Yeah, sure enough, that evened out. Okay, now this is going to be a meningeal release where I'm going to support this. I'm going to drive at a slight oblique angle, release and pressure. Go on your side, face me, sir. Okay, now this is going to be a C1 toggle. very, very easy. Pisiform contact. Come in. Now, since he has a left convexity, again, he's neutral, get down to where he is, apex L1. Okay, go right on your back. Okay, now, he's got a left lateral shift. Oh, I already adjusted him. Yeah, but I'm going to apply a little bit of pressure. I'm holding him in a mirror image, neutral, and then a small lift in that direction. Just holding him for a second. Yeah, that one's all good. Now here's an anterior lumbar with a left rotation. So I'm cupping his head. My back leg lifts up. I'm push off of the table to save me. I contact flat hand on the lumbar, rotate over, and apply pressure in that direction. Now since he's got a slight rotation in the front, I'm grabbing the table and applying pressure in that direction. Rise up, sir.
Thank you, doctor.
That's
So-
real time.